Welcome everyone, and thank you for joining today's Leadership Huddle. Today's webinar, illustrating the value proposition of the physician in senior living, is the final Leadership Huddle of our 2021 webinar series. I'm Chuck Harry, NIC's Chief Operating Officer, and I have just one quick comment regarding the webinar's logistics ahead of the panel's discussion. If you need to adjust your audio for today's webinar, you have joined the webinar using either your computer's speaker system or your phone based on your audio access during your most recent GoToWebinar session. You can adjust your audio access to today's webinar through either your computer speakers or your phone using the settings in the audio pane, which is located on the top of the control panel on the right side of your browser window. Moving to our panel discussion, it is my pleasure to introduce our host for today's Leadership Huddle. Bill Shatraw is Chief Success Executive at Signify Health, the largest conveyor of the BPCIA program, as well as an industry leader in service offerings that promote value-based care across multiple patient populations. Over the past 10+ years, Bill has collaborated with many different health systems and hospitals in implementing operational and strategic models to improve their value-based programs and the patient experience throughout their healthcare journey. Bill served as a member of NIC's 2021 Spring Conference Program Committee, and we sincerely appreciate the expertise he brings to these discussions. Bill, over to you for the introduction of today's panelists.
Thanks, Chuck, for the introduction, and good afternoon, everybody. It's my pleasure to introduce today's panel. Dr. Michael Poku is the Senior Medical Director for Oak Street Health, a network of primary care centers that delivers value-based care to adults on Medicare. Michael's passionate about developing and implementing novel care models and is a proponent of whole person care. Dr. Jennifer Rucci is a nationally recognized geriatric psychiatrist who specializes in the study, prevention, and treatment of mental disorders in the geriatric population. Dr. Rucci has worked in community, mental health, hospital-based psychiatry, and psychiatric emergency services. Charlie Trusker is the president and CEO of ALG Senior LLC, formerly known as the Affinity Living Group, as well as the founder and managing partner. Mr. Trusker has 3 decades of experience in both the development, operations, and management of senior living and healthcare facilities. Welcome, colleagues. Before we dive into today's moderated discussion, let's set the stage and help the audience familiarize themselves with each one of your organizations. Michael, do you want to start?
Yeah, sure. Happy to chat. So I'm Senior Medical Director at Oak Street Health. And as Bill mentioned, we are a large, now publicly traded chain of primary care centers. We have over 100 centers now and growing. And our model is unique in that we take on sort of total cost of care in our patient population, specializing in seniors and the Medicare population. And it really is our challenge to figure out and to, to pursue things that really drive quality of care. And how do we drive care outcomes up, and how do we drive costs down? So really have that financial alignment in that posture towards whole person care, as Bill mentioned, and making sure we do right by patients and families.
Excellent. Thanks, Michael. And Jennifer.
Yeah, hello, welcome everybody. Excited for this chat today and the opportunity to interact with you guys afterwards as well. I'm one of the founders of a company called Aventis Whole Health, and we've been around since about 2013, and we were developed as an integrated whole health person-centered care model for residents of long-term care communities. So everything from SNFs to assisted livings to independent livings and now actually even home patients, to really understand the continuum of patient care in that geriatric and other sort of special needs population. We operate in about 5 states right now, and we love partnering with our assisted living communities for the betterment of the patient outcomes, again, at a reduced cost. So excited for this talk today, and we look forward to it.
Great, thank you, Jennifer. And last but certainly not least, Charlie.
Thank you, Bill. So great to see everybody today and speak with you with this passion that we have for the care of our residents. ALG Senior is a company that is focused on an integrated healthcare model for our senior housing residents. We're excited about the opportunity to share with all of you what we do and how we do it. Thank you, Bill.
Excellent. Well, thank you everybody for the introductions. And as we get in here, or as we get moving today, really just kind of want to take a minute and level set on how folks are paid, and really a possible shift that we're starting to see in senior housing. And I think over the last few years, and something that presents itself as a possible or potential opportunity in the future, is really that transformation of senior housing and moving from a social model as we've come to know it and embracing more of a medical model. Now, by no means is that set in stone, but something that we're seeing is starting to present itself as an opportunity in the market. And in doing that, just to level set on how physicians are compensated, I want to just ensure that everyone understands that medical directors in skilled nursing communities are compensated by the facility. Today's discussion is really going to be about around primary care physicians and specialists, or PCPs, within the assisted living communities primarily. And when we look at that, these PCPs are actually receiving compensation for their services through health plans such as Medicare, Medicare Advantage, or the Medicaid plan that is associated with the individual being cared for. So in saying that, we'll kind of start with our questions here. And I guess, Charlie, let's start with you first, but how and why do you believe, or have you seen some senior living operators move more towards that medical model?
Well, Bill, it's the natural progression of our industry that we have seen since the mid-90s. We very early in our industry became a dichotomy of social models versus medical models. And really what we've embraced, especially with Jennifer and her team, is an integrated model. The social model still remains extraordinarily vibrant and important in our industry. We need it and we embrace it as a company. But what we've had to do, because of the increasing acuity of our residents, because of advancements in medicine, because of advancements in technology, and the expectations of our residents and their families, is to embrace more of a medical posture than we have ever had to do in the past. There's an increasing expectation on the part of our residents and families that we, as providers of assisted living, have somehow acquired the responsibility of the coordination of care of those residents, and to be the overseer and partner with our primary care practitioners to ensure that the entirety of the resident is taken care of. Bill?
Excellent. Thank you, Charlie. And I'll pass it on to Jennifer to really answer the same question. How are you seeing from your vantage point those operators move more towards that medical model in these facilities?
I absolutely have seen that happen more recently too. Again, our experience kind of in different levels of care, so working also in long-term care, skilled nursing homes too, it's clearly been there first. But we all know the acuity of the patients, as Charlie was saying, has changed. So the skilled nursing home patients look more like hospital patients. The assisted living patients look more like the old days of skilled nursing patients, and so on and so forth. And in an effort to really treat patients at the lowest level of care as possible and maximize their time in that space, then the need for those medical services has increased. And I would also say, just like Charlie was talking about, that it doesn't have to be a choice, between a hospitality or a medical model. I would actually argue you can have both, that you could still provide a very, very hospitable, warm, welcoming home, to your residents in assisted living communities, but also embrace the role, as Charlie said, as care coordinator to the medical service lines. And for us at Advantage, that's something that I really appreciate being able to do. And when we first started the company, even just not that long ago, 2013, the assisted living community, aside from some real good stars like Charlie, weren't even thinking this way at all. I remember early conversations with Charlie were very much about this, and how do we work together? How do we get better healthcare outcomes for our patients, improve their healthcare as well as their longevity in the assisted living community together. Because unfortunately, what I was seeing in many other communities, and still sometimes now, is really a split between the medical service line and the homes. And so I'm really excited about this talk to be able to bring those things together even more so across the industry.
Excellent. And thank you, Jennifer. And then Michael, from your perspective, how are you seeing these senior living operators move more towards that medical model, and how has that changed over the last few years for you?
Yeah, I mean, I think in part, and I totally agree with what Jennifer and Charlie said, right? I think the thing I would add is that in part, this is demand driven, or what operators are noticing is that their residents are increasingly expecting these services to be offered, and evolving from that social first model to be a more comprehensive biopsychosocial perspective. And hey, how at the end of the day, the patient, member, resident, depending on your vantage point, they just want to be healthy. They want to be out of the hospital, out of the emergency department, and they're looking at the different stakeholders that they're looking to for aging in place to say, hey, why isn't this happening? Why isn't this other thing happening? And who's really going to integrate it and really bolster my care, my health, and my well-being?
Excellent. And when we look at that, and I think you hit on a couple of big points, right? As we move towards this medical model, and all three of you have said we're trending in that direction, there's the opportunity to take a new look at physicians, right? How do physicians fit into this model? How do they fit into senior housing now in comparison to how they used to in the past? And when we look at this, what does the physician mean in the facility? And looking not only at the inclusion of physicians, but breaking that down further into primary care physicians and then specialists, and really looking at them as being the providers to improve the well-being of a community as a whole, right? And if we can enhance the well-being of a community, who does that sit with? Who do we rely on to do so, and who's ultimately responsible? And ultimately, we're going to need alignment between those PCPs and specialists in order to really enhance that well-being in the most optimal and effective way, right? So with that, Michael, we'll start with you with this question, but what do you see as being the benefits of strong alignment between primary care physicians, seeing residents in senior housing communities, and then medical specialists like cardiologists, podiatrists, and others becoming involved? Where do you see the strongest benefit being realized there?
Yeah, I mean, as we sort of approach increasingly organizations like us, obviously, and others going towards value-based care, it really becomes about not talking about things in a medicalized content, right? Moving away from that context, and it's really about how do we keep people healthy and well. And increasingly, right, as we age, we tend to need more medical care. We need more services. We need more social care, et cetera. And again, thinking about it from a person-centered perspective, that resident doesn't care what that looks like. They just want to be taken care of. And as they get more medically vulnerable, socially vulnerable, it does require, alignment with specialists, whether that be neurologists, psychiatrists, cardiologists, et cetera. So it's just it's part and parcel with this notion and this concept of how do we take really good care of somebody who is quite vulnerable from a medical and social perspective. And that means increasingly aligning with specialists who do have a certain degree of specialization, obviously, that primary care providers can't always stand in for. Now, primary care is a huge component, right, because it's been chronically underinvested in for a long time, but there are certain instances, many instances, that require close alignment between that PCP, that particular patient, the resident, and that senior living environment. So how do you vertically integrate, either frankly or through close alignment in financial incentives in other relationships? And I think that's a key component. So as we are getting better and better at this, as a medical community, as a social community, as a assisted living community, and then we're working together, we're finding that, hey, in order to achieve that next level of value, we need to bring other stakeholders in and really lock arms.
Excellent, and thank you for the insight there. And I think, let's talk to the specialist in the room. And Jennifer, when we look at this from your vantage point, right, being a specialist and having the ability to go in and work with these PCPs, what do you see as the benefit, not only for you, but for the patient as a whole in this situation?
Yeah, I mean, absolutely, you're right. As Michael also said, primary care is at the core, right? So you have to have primary care services for these patients. And, even before we get to the specialist level, I think there's a lot to be had and discussed, just in that, about developing core alignment with primary care providers, for your communities, where you can discuss cases with them. I mean, what I see, even because our company provides both primary care and specialty services, and I help as the chief medical officer to try to integrate those services together. And so what I see delivered, when a primary care service is brought to the patient, and there's that tight alignment with the facility, is incredible. I mean, having the ability to, come into that home, see those patients where they are, see what their room looks like, interact with the staff regularly, and in just such a better patient outcome way, which is always, as a clinician myself, at the forefront of why I'm doing what we're doing. But I also know it benefits the facility too, that the operators are better off when this service is delivered to them for silly little reasons, perhaps like transportation costs and convenience, but also in the improved outcomes and better retention of their residents. And then you can add, the icing on that cake with the medical specialist model. And, so many homes don't even have that primary care foundation, brought to them. They're having to kind of scatter through the community to get kind of care for their residents. But then if we're able to add on to that medical specialties, obviously my specialty is psychiatry, and the behavioral health component that the residents need, as everybody knows, who's on this webinar, is incredible, especially over the last year with all the stressors to this industry and to this population. That is just so key to improving the primary care outcomes themselves, but then also resulting in kind of a safer environment for our patients and our residents. And then you think about all the other medical specialties, because there's a lot to primary care. Primary care kind of runs like the quarterback of medicine, right? You see all these little Venn diagrams of integrated care systems, and, everybody places different little spheres everywhere and links them together and tries to put together this integrated healthcare team. But we really do we try to keep the patient at the center of that, the primary care sort of as a very key component of the bubble around that patient. And then you start adding in other little bubbles around that hub of the patient. So you add in behavioral health services or other medical specialties like cardiology, orthopedics. Isn't it nice if the resident were to have a small fracture, for instance, even, and not have to send them out to the emergency room, to be casted, to be able to bring that service to that resident? That is amazing. Or instead of having 911, be the first dial for the facility staff members, have them call us instead, or another medical service that can then help to provide either the primary care or the acute visit or the medical specialty to that resident. And then the outcomes just become better. You wind up with proven better outcomes for the patient clinically, and you wind up with better systems for the operators as well.
Excellent, thank you. I couldn't agree more with that. And I think when we look at it from the third perspective in the room and the operator, right? So Charlie, what's your take on this, right? When you see that alignment, what do you see are the big benefits, not only to you as an operator, but for the patients involved?
Indeed, and Jennifer and I talk a great deal, so quite often we sound very similar in our discussions. Senior care, assisted living, independent living, it's a team sport. And you do have to have a quarterback, and that quarterback is the PCP. But we can't lose sight that we, as providers of assisted living, as provider of senior housing, we have a integral part of that team. We know what's going on 24/7. We see it before anybody else sees what the residents are experiencing, feeling, and having to address. So it's up to us to be extraordinarily intuitive and watchful so that we can get that data, that information to the parties that can really make a difference in the healthcare of that resident. It's up to the PCP really to define the end goal. What is the end goal with that resident, and to work closely with that resident, and then to communicate that to us as assisted living providers, and then to allow us to work alongside them with the medical specialties, so that if we see things that are askew, we can get that information to the PCP. Now, this model is much different than the traditional medical director model, much different than the casual physician coming through on a monthly basis to see what's going on with their patient. It's a very interactive, collaborative method that if we don't start doing, we're going to see increasingly our lengths of stay diminish. You know, the easiest resident to obtain in our marketing world is the one we already have. And we need to focus on those folks in our communities and keep them there. When they go out the door, for whatever reason, we are putting them in harm's way. The hospital is not a safe place to go. Staying at home with the care that can be brought into the community by folks like Jennifer and Michael, that's the future of what we're seeing and experiencing. So we have to be very much a collaborative team member of this team sport that is now being created. Bill?
Excellent. Thanks, Charlie. And thank you to all three of you for the insight there. And I guess kind of like building upon that a little bit, and I want to go back to like the specialist aspect here. Jennifer, can you expand upon, I guess, the on-site presence, right, of a specialist, and what value one can that provide to the patient, right, and then not only the patient but to the community as a whole? And do you think that's currently realized as even an option when you look at residents that are in senior housing, senior living, or something that needs to be realized over time as this model continues to evolve?
I would say it's not nearly as realized as it needs to be. And it's probably not even available everywhere. There's a lot of communities, depending upon where they are in the nation, that don't have an option, don't have a service, like ours or like Oak Street or others that can come in and provide that on-site service. But I know the difference it makes when it's provided. I mean, I've worked in both settings. I've worked in, office-based practice where residents of long-term care communities would come in, with their, maybe an associate that knows them, maybe just a transport person, from the community, maybe with any medical records, maybe not. And trying to, care for them as the physician is extraordinarily difficult. And versus when I'm able to provide those services and we're able to provide those services on site with the patient, seeing them, seeing their room, seeing their environment, seeing them interact with each other, talking to them as they're walking through the hallways. And as Charlie said, one of those other circles on that hub of patient-centered care are the facilities, are the staff members who are with them 24/7. And so, I train all of our practitioners, when they're in there to interact with all of the staff. We have a, ability to get so much more information, than when we're in an office building. So I've seen the clinical outcomes change, as a result of that. We've seen, better care on those patients, whether it be things like reduced medication burden, which comes with, reduced cost to the system as well, reduced ER visits, reduced falls, all these sort of things that are able to happen when you not only have the primary care on site, which again is its first sort of barrier to entry of improving their care, but then also bringing in the specialist. It just really changed the world of the resident. And then, the proposition for the operator then is, just as Charlie said, if you have better care for your residents, and really embrace being a part of that care model, then as a result of that, you're going to retain your residents better and also attract some. This is something that can be advertised, to prospective clients as well as, look at this awesome service we're able to provide for you. Increasingly, families are expecting that, and so are residents.
It's a great point. I think when you look at that, right, from a resident perspective, they may already have, a physician that they see for primary care, a specialist that they see for, the specialty services that are needed. And they're going to have a lot of different thoughts on who needs to be their physician, whether it's, them leaving a community, which we're trying to prevent, or who's on site. And there are, when we look at just reality here, there are a lot of, strategic alignments between physician groups outside that kind of, come to bear when we look at alignment here. And I think it presents an interesting, I guess, hurdle that many people do need to cross in terms of that alignment. And Charlie, from an operator standpoint, right, who do you feel owns the responsibility for that alignment? Is it the community? Is it the PCP? Does the specialist have, you know, a large stake in that? What would be your response as an operator to that?
Well, it's a collaboration to begin with, but primarily, I think it belongs to the provider of the assisted living. In our case, it's us, ALG. And if you think of alignment in terms of creating a network and then narrowing your network, right now, your facility, your community has a network. Whether you know it or not, whether you're managing it or not, it exists. And why not get in front of running that network and lead the parade instead of follow it? And then consider this, which is what we're doing right now, narrowing your network, reducing the clinical variations and improving the outcomes of your residents will result in a higher census, will result in a better marketing effort from the standpoint of reputation, and frankly, will help reduce your regulatory deficiencies and survey problems. You know, we're about to see, as we come out of COVID, Bill, a increasingly aggressive regulatory scheme. We've seen it at the federal level, even now through OSHA, and you're starting to see it at the state level in the 7 or 8 states that we operate in. It's going to get even more and more difficult, and we are going to be evaluated on how well we comply with those rules and regulations. And if you have a lot of variation in your network, you're not going to be able to comply with those expectations of the surveyors. So from my vantage point and from what we're doing, our strategic analysis is you own it, Mr. Provider. Bill?
Excellent. Thanks, Charlie. And Michael, from the PCP, perspective, anything to add here? What are your thoughts on that?
Yeah, no, I mean, I think Charlie's and Jennifer's thoughts on this were so poignant. I mean, I would say that from a PCP's perspective, particularly someone like us who takes on full total cost of care risk, I do believe it is a collaborative model, and it starts and ends with that alignment. And you can get that financial alignment, you can get to the table, and you can really come up with some super innovative products to push forward to residents, right? And then it has a virtuous cycle effect because you can market it, you have a higher census, you have lower costs of care, right? So you have improvement to all the stakeholders. Because again, you've got to remember that the resident, the family just wants that resident to be healthy and well. It just wants to age in place in a way that's meaningful to them. And the provider, particularly the total cost of care provider, we're just trying to enhance quality and lower costs. And the facility is trying to, enhance their own standing and increase their census. So there's shared alignment across all the three if you can get it right. And then it's just about how do you drive that to quality and how do we get deeper with the other stakeholders, knowing that, for the first time in a long time, the various stakeholders in the system are all aligned to move in the right direction. Now it just becomes who has the best mousetrap, who can come up with the best ideas, but the refreshing thing that it's all to the benefit of that particular resident, that member, that patient.
Excellent. And I think you hit on a couple of things there, right? You mentioned total cost of care, right? And the PCP kind of being responsible for that. And I think one thing it kind of begs the question of is, over the last few years, people have talked about, movement away from fee-for-service and towards, value-based care, right? And I think we're at a point where it's no longer it's coming, like it's here, and it's very prevalent. And over time, right, we're seeing health plans, we're seeing employers, we're seeing multiple stakeholders increasingly and at a very rapid pace really embrace value-based care concepts, right? So looking at a patient's care over a period of time, total cost of care concepts, instead of the current fee-for-service, system that, we have lived in, if you will. And And in that, they're working with physicians, providers to go at risk for these patients across Medicare, Medicare Advantage, Medicaid, et cetera. And a lot of, the residents in these communities are the patients you're seeing, in these communities as well. So I guess it kind of begs the question, right? When we look at value-based care concepts overall, PCP is generally, like we've said, throughout this talk, kind of the quarterback or the responsible entity for this total cost of care. And looking at this, it means they're also responsible for what happens to that patient downstream. So this alignment becomes critical and, in the care for these residents and patients. And that alignment is really leading to responsibility, right? And ultimately, who do we feel is responsible for where that patient goes for the specialist care as it moves downstream? And how do you navigate the needs and contracts for each party in these arrangements, right? The more players you get in here, the more complex it gets, and discussions, aren't always just as smooth as everyone would like. So in looking at all of those pieces of this puzzle, if you will, who do we feel is responsible and how do we navigate that? And Michael, let's start with you.
Yeah, the way sort of we think about that is really arming and putting that resident at the center and letting him or her and that family really, at the end of the day, as they always should, guide the decisions, but helping them, again, in a true informed consent basis, making sure that they're armed with data that they can understand, internalize, and sort of output. So one of the big things that we do is, we help to say, hey, here are the folks that are a network. We've got some data that helps to demonstrate, who is high quality, low cost, and who, based off the data, will you, Mrs. B, tend to do better with, and who we have, alignments with, or relationships with, and who responds back to us, and how can we help better be a quarterback. So for us, it's really about empowering that patient and allowing the patient to retain choice, but making sure that they're armed with the data that historically just hasn't been available to that consumer, to that resident. And we have found, hugely beneficial output just from that, to say, hey, here's sort of how we think about things. Let me show you on a risk-adjusted basis how this specialist does this as this other specialist. And oh, by the way, if you go to the specialist, we historically haven't really heard from that person. We want to try to be a quarterback. We want to try to be a good partner. I just want to let you know that it's a real tough time for us to get in touch with that particular individual. So really letting that patient, that resident, that family know what's what with respect to the data and what's what with respect to the communication pathways, which are key to keeping somebody healthy and out of the hospital.
Great points. And Charlie, thoughts on that?
Well, we are in the process of moving into a Medicare Advantage world, and we're trying to be a leader in that as we begin our own Medicare Advantage plan. So as owner of the network, so to speak, as the plan becomes, we have to be very proactive and very involved in the creation of the network and who's involved and who isn't. So as we align our interests on the community side along with the payor side, it's necessary to bring to the table, so to speak, specialists who are responsive, who do have quality outcomes, who do limit the variations of the care, while giving the opportunity of choice to the resident and their family. We have to educate, as Michael has said, and lead the conversation so that they understand who, what, where, and how things are going to get handled. We have seen situations where specialists have, for instance, prescribed medications that when the primary care practitioner finds out, has to discontinue simply because they are working in a counter effect to the rest of the wholeness and care of that resident. So we very much, as healthcare providers in today's world, have to very much lead that conversation.
Excellent. Thanks, Charlie. And then Jennifer, right, kind of being where you are and that downstream, provider, how do you feel about, the navigation of that? And how do you feel like you can ensure that you're meeting the needs of not only the patient, but that community as well, in navigating the system.
Yeah, no, I think that's important. And it's always interesting to me to, hear Charlie's thoughts too, because he's such a pioneer in this world. And, if well before anybody's talking about value-based care in assisted living communities, just look what Charlie was doing 10 years ago, or look what the SNFs are doing right now. I mean, I can report from the SNF world. I may even see a majority of them at this point are in some sort of value-based arrangement, with hospital systems. Their discharges, are determined based upon that. And guess, what's coming next to the assisted living world as well. And so the faster you can, as a community, as an operator, get ahead of that, the better off you will be. And it's important, for us too. I love the idea, I think Michael said it first, about, education and providing information to the residents. We're in a different world of medicine now, and we're in even different worlds, based upon, what has happened in the last year and a half. What probably would have taken another 10 years, I would say, in changes and shifts to value on the national level, is probably going to happen even on a faster pace, because people were sitting around for the last year and a half trying to figure out cost of care and how to evolve healthcare, because there wasn't a lot of other things going on, as far as other healthcare evolution and practices. So it's been really interesting. I think it's going to happen a lot faster. And I think this space is specifically tuned. You have, sort of a captive audience space of residents and patients, mostly, or a lot of them are government insured. And so the opportunity to probably really make this population the first national population that will be in value-based contracts, there's no doubt about it, in my mind. And so from us on the clinical side and on the specialist side, we want to be a part of that. We want partners and collaborators, on the operations side. I love working with corporations that are interested in that want to talk about these things and think about this language. It starts with some of the regulation, and that word that Charlie talked about earlier as well, because, that's how they start to pay attention first on the payer side and on the government side, is they look at some of your outcomes and they'll start to work on things on the regulatory side. And when that doesn't work enough and they don't get what they need that way, then they start on the money side, and start working on, both the push and the pull on the finances. And so again, it's coming, and the faster and better that we can work together, to provide those clinical outcomes for the residents, that's in everyone's interest, residents, medical operators, and facility operators.
Great. And I think, all three of you really hit on, two key points here. One, outcomes, and two, the data that sits behind those outcomes, right? And, we talk about data, and I think just, as a nation now, we're so data heavy. There's mega data sets, everywhere we go. And sometimes it becomes too much, right? And one key aspect is determining, one, what's the right data? Two, are we looking at everything that's relevant? And three, at what point does data become too much and we've got pieces of data coming, from every angle that don't necessarily align, right? So in looking at that, I would say, and as we move towards that medical model or the potentially move in that direction, do those valuable data points change, and where does the data come from? And I'll just kind of tee it up now. We may have a couple of different answers here, and how do we get to that alignment of those data points across, all three constituents here? So Charlie, what are your original thoughts on that?
No data, no trust. If you don't have that data, I can't trust you. So all the members of our network have to provide us their data, and we reconcile it with our own data. So all the doctors and primary care practitioners inside of Jennifer's company, we have all of their data, both from them as well as our own from them. So we're tracking, for instance, all the medication orders and the type of medication orders. And then we're mining that data to try to find out who's the outlier and who's prescribing medications. And I pick on Jennifer because she's on the screen, but all of our practitioner partners, we are sitting there looking at who's creating a fall risk for us because of the type of medications that they're asking or prescribing, and what combinations of medications are out there with our residents. We had one resident, the resident with the most medications in our system were 32 medications. And we went after that physician group very aggressively and got that back down to an appropriate level. You know, I'm not a doctor, and I didn't stay at a Holiday Inn last night, Jennifer, but I can tell you, I've been told by you and many others that you can really only absorb about 8 medications, and anybody over that 8 medication number, you really have to evaluate. So that has become our new ethos, and that is what we're studying. But medications are very easy. We're looking at other things like incident reports and watching for falls, watching for congestive heart issues that discontinued medications may have caused. For instance, who discontinued by mistake, perhaps, some Lasix, and get in front of those issues and deal with it. So by having the data and mining the data and watching the data, we have a very active data warehouse. We have a chief information officer who has built fabulous Tableau reports that our teams look at virtually hourly to see what's going on. We have divisional clinical staff who is also surveilling that data and mining that data through our Tableau systems. And it's interesting, when Jennifer and our team get together, we sit there on the screens and compare the data and look at it. And we do the same thing with our pharmacy partners and hold them accountable as they do us. So it's very revealing, and I cannot emphasize more the need for all of my industry partners and peers to begin undertaking collaboration and creation of data points. Bill?
Excellent. Thank you, Charlie. And Michael, thoughts on that to follow?
Yeah, no, I think Charlie's comments were great. I mean, what I would say is we will, as a collective community, for all the stakeholders involved in senior living, get better at this over time, right? And I sort of liken it to hospitals. If you look at the hospital industry, I think it was Clayton Christensen in his book who said, 30 years ago, 70% of the folks who we take care of on the hospital floor would be in the ICU. And 30 years ago, 70% of the folks in the ICU would be dead. But we've gotten so good from an acute care perspective, because that's where a lot of the money has flown for the last several decades, that you've seen marked improvements. This will be very similar as we march towards value-based care. We're seeing more and more investment, more and more interest from research, from private equity, from risk capital, and data is such a tremendous piece here. But the risk is, which I've seen a lot of folks sort of fall victim to this, is more data isn't good data, or more data isn't good, period, if it's not processed, right? We have to really strive to convert that data into insights and information that we can use to better the life of that particular patient, that resident, that member. And I think that's the trick. For the time being, absolutely, there's low-hanging fruit because there's the evidence base out there. Charlie mentioned a good one in terms of deep prescribing, fall risk and things of this nature. But then there's the piece of where we really leverage all the buzzwords that we hear today, right? Where do we think about artificial intelligence and machine learning? Where do we think about natural language processing? Where do we think about big data and how we can derive insights thereof? And that's going to be the big thing. But the nice thing is that we're all sort of collectively working towards the same thing.
Excellent. Thank you. And Jennifer, I'll let you finish that out.
No, I mean, I think this is a good endpoint, is to really think about it, because that's how we get to the next step. That's how we get to value, is by collecting these data points. And I love it. I love being held accountable, to our clinical outcomes. We all think we're doing a great job in medicine. We all think we cure everybody and everybody's doing wonderful. But the no data, no trust line, I think, of Charlie's is absolutely true. I mean, I want to see that. I want to see that we're outperforming, that our patients are improving, that our facilities are happy. And we have certain data, electronic health records really were the impetus to develop data points for healthcare. And it wasn't just because they wanted us to click stuff, it's because they were trying to collect some data. And it's all building to the same thing that we're talking about. We have some in our world on the clinical side, the homes, the operators have their level of data with lengths of stay and other things. And if we can, again, it keeps coming back to that collaboration. If we can work together on all fronts, including on the data front, then that's how we're going to really advance together.
Excellent. Great. And thank you, Jennifer. And as you said, I think this, is a great point to kind of end the discussion and give people, something to think about is how do we bring this data together to really be able to, accelerate the change that we're currently seeing in senior living and continue on that path that, is really ever evolving and has been going on now for a little bit of time. So a special thank you to the three of you for being on today's panel and for a really nice discussion. So Chuck, I'll hand it back to you.
Thank you, Bill. And I'll second Bill's thank you to Michael, Jennifer, and Charlie for your insights on the value of the physician within senior living. We welcome those of you who are able to do so to join us for the follow-up group discussion to today's leadership huddle. If you're able to join us, you're welcome to click on the Zoom link, which is now posted in this webinar's chat. The Zoom session for the group discussion will begin shortly at 2:50 Eastern and will conclude by 2:30 Eastern. Nick also welcomes everyone to join us for the in-person 2021 Nick Fall Conference, taking place November 1st to 3rd at the Marriott Marquis Houston. Registration for the conference is now open and early bird discount registration rates are currently available. To register for the fall conference, please visit our website at nic.org/fall2021. With that, we wish everyone a good afternoon and thank you for having joined us. We hope that this NIC webinar series has afforded you insights on advancing access and choice in the housing and care for older adults. This concludes the webinar portion of today's Leadership Huddle.